Thank you.
Chair, the next witness this afternoon is Ms Sandra Carver.
Thank you. Repeat after me, please. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Thank you.
Thank you.
You can sit down.
Thank you.
Thank you. Can you give your full name, please?
Mrs. Sandra Calver.
And you've made two witness statements to the inquiry. They're at DWF 509 and DWF 4016. And Chair, I'd ask that those witness statements are reduced in full, please.
Indeed, thank you.
Ms Calver, because those witness statements stand as your evidence, I'm not going to ask you about every single thing within them, but I'm going to ask you some questions about your role as Head of Healthcare at Brookhouse, and then about some specific topics that you were involved in the relevant period and now.
Thank you.
Your witness statement is, I think, first witness statement is at tab 1 of the bundle in front of you. So if you want to have that open in front of you, it might help you just to navigate with me. So first of all, I just want to ask you about your background and the roles you've held. You qualified as a registered general nurse in 1986.
That's correct.
And you say you've worked in various hospitals, and from November 2004 you started as a night nurse at Tinsley House Immigration Removal Centre, employed by Saxon Brook Medical in a team of 4 nurses.
That's correct.
In 2009, as we know, Brookhouse opened, and the team, you say, expanded to cover both sites, and you became the deputy nurse manager covering both sites, and then transferred to G4S in 2012, becoming clinical lead.
That's correct.
And what does the role of clinical lead entail?
It was looking after all the nursing staff and leading the nursing team. So being in charge of all the nursing roles, giving them supervision and ensuring they're undertaking the correct clinics, etc.
And you then say that in 2017 you were made Head of Healthcare for Tinsley, Brookhouse and Yarlswood Immigration Centre in Bedford.
That's correct.
And in 2019 the Yarlswood contract ended and you moved back to be based at the Gatwick IRC.
That's
Is that
correct.
right? And what's the difference between Head of Healthcare and Clinical Lead?
Head of Healthcare, you're looking at the whole process. So all of the contracts, you're looking at financial, budgetary control, as well as just the clinical aspects.
And do you line manage the clinical lead underneath you?
Yes, I do.
And the clinical lead for Brookhouse at the time in 2017, was that Chrissy Williams?
That's correct.
At paragraph 4 of your statement, you set out additional roles that you held, and you mentioned one in particular, safeguarding lead, and you say trained to level 4 standard.
That's correct.
What does the role of safeguarding lead entail?
So that is being giving guidance to all the safeguarding aspects within the healthcare and looking at any referrals that do come through, ensuring that they are put to the right, to the local, looking at going to the local council if required, or if any safeguarding concerns needed to be raised, that they would be raised appropriately.
I see. And what does level 4 training mean?
That's a 2-day training course, so it is further in depth. So you're looking at being an overviewer of all of the referrals, rather than just doing. All of our staff are level 3 trained because of the care for both children and adults. Level 4 is that next level up, and that is a 2-day course.
And is it the top level?
No, this level 5 would be a regional managerial post.
I see. You say that in between 2016 and 2019 you spent 3 days a week at Brookhouse. How many days a week do you now spend there?
5 days a week.
And you say that the contract transferred to PPG on the 1st of September 2021, and your employment transferred to them at that time. And am I right that you're still working as Head of Healthcare in Brookhouse now?
Yes, that's correct.
I want to ask you a few questions about the culture of the healthcare team in Brookhouse at the time in 2017. And you say that the healthcare team tried their best to create a caring, compassionate culture at Brookhouse. How did they go about doing that?
I think we worked very closely all together, but we also worked with the officers as well. So we'd spend time doing as many extra services as we possibly could, looking at the full care for the patients. We tried not to call them detainees, they were patients to us, as they would be within any healthcare environment. And we want to do our utmost. A lot of the people had not had previous healthcare experiences, so to give them as much input as possible.
And what role as head of healthcare did you take in particular in trying to create that culture?
Having healthcare promotion calendars, so ensuring that and getting staff to actually undertake healthcare promotion, and trying to look at different ways that we can work our health services for the benefit of the patients.
Yes. You say at paragraph 109 of your statement that staff acted appropriately in managing intoxicated residents, but occasionally there were 1 or 2 detention staff who made silly comments, but nothing to cause you concern. What do you mean there by silly comments?
I mean, looking back at the footage, it's seeing some of the comments that were made in the footage and being derogatory to the patients. It could be that they were talking to them, undermining themselves. I can't think of any specific words that they were using, but...
And are you referring there to detention staff
Yes.
alone or healthcare staff as well?
Detention staff.
Detention staff. If nursing staff were present when those type of comments were made, what would you expect them to do?
Report it back, specifically to myself. If they haven't reported it to myself, they could report it directly on what's called an SIR, one of the serious incident report forms, through to the custodial team.
There's an incident we've heard about on the 14th of June where Nathan Ring was saying things such as, does your face taste nice because you appear to be chewing it off, in relation to a detained person who was intoxicated with spice. Is that the sort of thing you're referring to?
Definitely.
And would you have expected a nurse present when those sorts of comments were made to report it back?
100%.
Would you expect a nurse to have been saying comments such as homies after your coke?
Definitely not.
That's completely inappropriate.
Very much so.
And where a nurse is caring for and conducting observations on a detained person who has been unconscious due to intoxication with spice, and says along the lines of these comments, let's open your eyes, oh, like saucers, that's what we like. You've had a good old time, haven't you? Was that fun? You enjoy the good time. I think you enjoyed your stash, that's going on. Again, would you say that that comment is just a silly comment, or is that inappropriate by healthcare staff?
I do think it's inappropriate.
If you had heard comments of that nature by your nursing staff, what would you have done?
I would have spoken to them immediately to explain to them that they actually is not appropriate for them to be talking to any patient like that.
And the reason it's this type of language isn't appropriate is because it's dehumanising and
Correct.
degrading. You presumably accept, as indeed I think Joanne Buss does, that the comments we see her make in the panorama footage in relation to D1527, he's an arse basically, and that which follows, those are completely inappropriate
I was
as well.
horrified when I saw that.
You do say in your statement at paragraph 153 that staff need a safe private place to talk to colleagues and decompress, and you say isolated moments of black humour are often simply a way of coping with a difficult situation in what can be a challenging environment. But you'd accept that where these type of comments were made was in the presence of detainees.
Yes,
And that's another reason why they're inappropriate.
totally. The safe space has definitely got to be confined space, away from any detainees.
And the language, some of the language that we see, though, from the likes of the detention staff, such as div, scrotum, the types of derogatory words applied to detainees, do you say that if it's in a safe space that that's appropriate or not?
It's not appropriate. I think sometimes it's a way of people getting out of their frustrations So if it's in a safe space, you can allow them to talk, but explain to them afterwards about the appropriateness of it.
I see. There's been some comment in reviews such as the Shaw Review about a culture of disbelief within the healthcare department. Do you have any particular comment to make about that as it refers to 2017?
No, I mean, we had a lot of residents that actually that felt that healthcare would actually be working with Home Office to say people were not fit to travel, or were fit to travel when they felt they were not fit to travel. We were just trying to do our utmost for the patients.
Because if it's right that there was a culture of disbelief, that is, healthcare staff not believing reports of symptoms or conditions reported to them by detained people, that wouldn't fit with the description of a caring and compassionate culture you've described, would it?
No, definitely not. And we would do as much as we can for each individual.
I just want to deal very briefly, because you're our first healthcare witness, with some general training questions. You say that you're an experienced registered general nurse and you've built up a lot of training through years of experience. You yourself completed a foundation management training course with G4S, which covered different areas, including grievance and disciplinary procedures. Is that right?
That's correct, yes.
You mention in your statement that there was an induction booklet at one time. Was there one in 2017?
I think we started one around that because we had CEDARs operating as well at the same time. So that was the one that we'd used previous to that.
And what sort of thing did the induction booklet cover?
It would talk about the routine of the day for both day and night for the patients. It would talk about the clinics. It would talk about training that was required. It would also talk about ACDTs, Rule 35s, Rule 34s, all of the DC rules.
I see. We'll come to those in more detail
Yes,
later, as I'm sure you'll appreciate. You also mentioned mandatory training online. Was that of the nature of things like health and safety?
Correct, yes.
And you mentioned mental health first aid. Just briefly describe what that training is.
That was a very brief training that we were given because as health professionals, we've had mental health training installed into us throughout our training for registered nurses.
Yes.
So it was a brief, just a refresh on training that was actually developed by our mental health lead at the time.
I see. You also talk about torture awareness training run by the Home Office and NHS England. Did you undertake that training?
I did, yes.
And when was that?
So I undertook one of the first ones. There was a further training that was actually put in 2017, which I was unable to go to because I was on leave at the time. There's been a couple of training sessions.
So prior to 2017?
Yes.
And generally speaking, what did that cover?
It didn't talk about the document of Rule 35 specifically, but it talked about torture awareness. So people's effects of torture, how it affect them, and the outcomes that could show.
I see. You mentioned Rule 35 training as being essential to the job. Is that essential to a nurse's job working in an IRC?
When I first started, nurses did undertake Rule 35s. They were completing them. Then the DCO rule changed, but it had to be a medical practitioner only.
Yes.
So now it's not given to nurses because they don't undertake those. However, the DC Rule 32, which is for short-term holding, which is exactly the same document, can be undertaken by a nurse.
So do you think it would have been beneficial for nurses to have the full training on Rule 35?
Yes.
Do they now?
No, because there's still very limited training out there.
And the reason that it's important, in your view, for them to undertake that training is that they play an important role in referring
Correct.
detained people to GPs in order to
They're asking
undertake
the initial
those.
questions.
Yes. So it's a screening type of role, because a GP may not know that a detained person needs to be considered for a Rule 35 report unless someone's referred the person to them.
That's correct.
When you did the training prior to 2017, did it cover all three limbs of Rule 35, the three subsections, or just the one concerning torture?
It was more torture awareness, so it didn't talk specifically about Rule 35, it was more torture awareness.
You also say that training ahead of policy changes would enable you to work more effectively with the Home Office. How did, in 2017, the Home Office cascade down knowledge and guidance in relation to new policies?
We did actually have adults at risk training for all of our staff, and at a push we managed to get the Home Office policy team to come into site and actually deliver that over 2 sessions, so I could get the majority of our healthcare staff to have that adults at risk policy. And they actually found that we were really engaging and asking a lot of questions over it as well.
And that was provided by the Home Office, was it?
Correct, yes.
You also mention ACDT, the document that's used to, and the system that's used to manage those at risk of self-harm and suicide. You say that when it came in 2007, you had training, but you say refreshers were very ad hoc. Given the importance of ACDT to the management of those risks, do you think that ad hoc training was satisfactory?
No, I mean, part of our orientation, we would actually go through the ACDT booklet and we'd advise all of our staff how to open an ACDT. So we'd go through that front page of the first awareness for opening up a document. But that was us as healthcare professionals doing it. It wasn't through the site doing them. So it wasn't the official training course.
And you thought that it would be beneficial for them all to
Definitely.
undergo the official course?
Definitely.
Do they now?
No, there's still it is better. We now have yearly refresher training for everybody, and all new starters do have to have some ACDT training to start. So that is improved.
Thank you. Just in relation to the management of healthcare staff, again, I'll try and deal with this briefly, but as you're the first person here talking about healthcare, it may just help to bring up a paragraph of your statement on the screen. It's DWF 509 and then page 6, please. I hope. And if you could just zoom in slightly on paragraph 27, the sort of table in the middle. Thank you. This sets out the structure of healthcare very helpfully in tabular form, which is more difficult to describe just using words. There you are at the top as head of healthcare. There were then the 2 clinical leads, Chrissy Williams, who we've heard about, and it says Joanne Bass there, but I take it you mean Bass.
Yes.
There were then practice managers, Michael Wells at Brookhouse and Jacinta Dix at Tinsley House. What does a practice manager do, very briefly?
There are your business managers, so they'd look after the budgetary roles, they'd look at stock ordering and all of the sort of senior admin role specifically.
Yes, so administrative roles, not clinical.
Correct.
Underneath, you then have RGNs, registered general nurses, and you give the numbers there. RMNs, registered mental health nurses, and then other nursing staff, including pharmacy technician, healthcare assistants, etc. And then 2 administrators, although you say 1 post was vacant during the relevant period. Thank you, you can take that down now. At paragraph 29, you say the clinical leads and the practice managers reported to you as their direct line manager.
That's
is that
correct.
right? And the clinical leads then, as you might expect, managed those senior nurses below them, and the senior nurses then managed the nurses underneath them,
That's right,
registered
steady
general
down.
nurses and mental health nurses. Is that right?
That's correct.
What happened in relation to bank staff in terms of management?
So they were looked after by the senior team as well. So bank RGNs were looked after by sort of the senior nurses and clinical lead, and the bank RMNs were looked after by mental health.
I see. You say that a healthcare manager was on call 24 hours a day. What level was classed as a healthcare manager? You?
Myself,
The
all the
clinical
clinical leads, and sometimes the business managers, but they'd always have myself as background for being clinical backup.
I see, thank you. You say that you had an office in the healthcare department and staff would approach you with questions, and you say that you worked collaboratively with the team. What exactly do you mean by worked collaboratively with the team?
We had one office, so the door was always open for all staff to come in and out. It was literally, we'd all work together to solve issues. I wouldn't let anyone do anything that I wouldn't undertake myself.
You also carried out clinical supervision. Just for those who aren't in a clinical profession, what does clinical supervision mean? What does that entail?
It'll be reviewing any incidents that have gone on, asking them for reflective practice of how they feel that that incident went, if there's any changes they felt they could do, anything that we could change within healthcare together, but also looking at safeguarding aspects as well.
And was that of nursing staff only? You didn't have, and the clinical leads didn't have any role in the clinical supervision of GPs, for example? No. Do you recall any particular issues being fed back to you at the relevant time in 2017 from clinical supervision?
No, nothing.
Moving on then to reception and induction of detained persons. At paragraph 61 of your statement, you say that all detainees underwent a health screening on arrival within 2 hours.
That's correct.
There could be an occasional set of extenuating circumstances if something exceptional was happening in the centre, for example, an emergency. Are you there referring to where there were delays in the health screen happening so that it didn't happen within 2 hours?
Yes, that's right.
And was that a regular occurrence?
No.
What? There were only delays in extenuating circumstances?
That's correct.
What about when there were large numbers of arrivals of detainees?
Again, that could be that you'd see them for very briefly on as they came off of the bus, but then you'd actually go through their full process afterwards. So you'd have seen them, but you wouldn't be doing their full documentation within that 2 hours. It may be 3 hours by the time you got to see them, but they would be completed within that as soon as possible.
And at paragraph 62, you say that screenings were done 24/7, so at night as well.
Yes.
Did that cause challenges or problems?
Main challenge would be if it hit over medication time for the night time, because often you've got one nurse doing medications, that limits the number of staff around. We'd only have 2 nurses on at night. That could be one trained, one healthcare assistant.
And so were screenings carried out by a nurse or a healthcare assistant?
Yes. If they were completed by a healthcare assistant, they were reviewed by a nurse as well. They had to be reviewed to ensure that they had hit. There weren't any referrals that needed to be done as well. So we always made them be reviewed as well.
And when did that review take place in relation to the screening by the healthcare assistant?
As soon as possible. So within that shift, definitely.
I see. Briefly then, what did the screening process cover? What sort of things was the screening process designed to bring out?
Physical, mental health, vaccination background, medication backgrounds, any previous history of self-harm. And they did ask if they were being tortured as well.
What was the primary purpose of the screening at that time?
To safeguard the patients.
And that safeguarding, was that focused very much on the fact they had just arrived and so keeping them safe immediately overnight, or was it a longer forward-looking process?
It was longer. In a prison circumstances, you'd have first screening and second screening. In the IRCs, we just do one initial screening. So we do look at all of the things within that first screen. And it is to look at all of their care and make sure we don't miss any future ongoing care that is required.
The screening that you've been referring to here is carried out by a nurse or a healthcare assistant. So that is not, for the purposes of Rule 34, an assessment under Rule 34 of the detention centre rules, because that assessment's required to be done by a GP. Is that right?
That's the Rule 34 has 2 parts to it. It has the initial screening by a nurse within 2 hours, and then the screening by a GP within 24 hours.
Thank you. And that screening by the GP first of all, which you refer to at paragraph 67, within that first 24 hours, is that the one you're referring to as being the assessment required under Rule 34, or is it different?
Yes, that would be the one I referred to.
You have talked about the screening by the nurse initially, checking for vulnerabilities and mental health issues. What sort of thing is the nurse looking for? What's the screening designed to check for?
For any disabilities that they may have, that they may be vulnerable, it may be mental health, any mental health issues, any medications that need to be ongoing, any substance misuse that they may need treatment for.
Risk of self-harm.
Risk of self-harm on it, and infections as well, any infection risks.
And you say you would put in place an SLP at that point if vulnerabilities were uncovered. What is an SLP?
It's a supported living plan. It is a care plan, but it's one that's for use for everybody within the centre, so not a specific healthcare care plan. So if somebody had got any disabilities or anything and needed support with any daily activities of living, then that will be written into the SLP. If somebody had got any vulnerabilities that maybe claustrophobia or something as well, that would be put onto the supported living plan as well.
And was it also designed to provide support for mental health issues such as risk of self-harm or suicide?
Yes. So that would be more, if they had got an active risk of self-harm, then that would be the ACDT document that would be completed.
So you say at paragraph 70 that if there was a risk of self-harm and suicide, a nurse will open an ACDT immediately and alert the officers. That's the detention staff on the wing.
Yes.
And the ACDT document was designed to manage that risk of self-harm or suicidal intentions. I'll come in more detail to that later, but you then say that they wouldn't be taken out of reception until the custodial manager assessed them to ensure they would go to the appropriate place. What do you mean by the appropriate place?
Depending on how much observations they were requiring and their risk of self-harm. If they were a minor risk, they may go into a wing and only need to be reviewed every 2 to 3 hours or have conversations twice a day. If they were at a high risk of suicide, they may be required to go to the constant watch observation room. So therefore, we'd need to ensure that they weren't being put at any risk of moving on elsewhere.
And the constant watch observation room, was that on E-wing?
That was correct, yes.
Would they sometimes also go to CSU or not at that stage?
Not generally, because that would be behind a door that you wouldn't be able to see so obviously.
And whose decision was it as to where a detained person would go after the reception screening?
It was the officers, but it was often in discussion with ourselves as well.
So healthcare had some input?
Yes.
And what would you consider to be an appropriate place for someone on an ACDT, or does it just depend upon the circumstances?
It does depend on the circumstances. Some people may state that they're going to self-harm, but they've got no indication of how they're going to do it. They've got no thoughts of when they're going to do it or any plans of how they're going to do it. Another person may actually have obvious cuts on them, may sort of be very withdrawn, and they're obviously at a higher risk.
And is a history of self-harm relevant?
Yes.
You have mentioned E-wing and the constant watch rooms. You describe E-wing at paragraph 94 of your statement, and you say there are 2 constant watch rooms for ACDT constant watch. And just so we're clear, constant watch means exactly that.
That's correct.
It means an officer
24
usually...
hours.
24 hours, every second of every minute
That's
of
correct.
every hour.
Yes.
That therefore indicates a very high risk.
That's correct.
A high risk of self-harm or suicide, because they simply can't be left alone.
That's correct.
You also say that people who could be difficult for removals would also be put onto E-wing, so they were in a smaller area to make removal easier for flights. Is that right?
That's correct.
So E-wing was used for vulnerable people who were at risk of self-harm or indeed suicide, and who could be on constant watch. But it was also used for people refusing to be removed.
That's correct.
Who might resist their removal. and therefore who could be violent,
They
presumably?
could be, yes.
And who might need to have force used against them
That's
to
correct.
effect their removal. Is
Yes.
that right? Was E-wing used as a sort of de facto way to impose additional restrictions on people who you didn't know how to manage them otherwise?
Sorry, I didn't quite understand that one.
Well, were the people being sent to E-wing capable of being managed anywhere else?
I think the majority were appropriately placed. We had, if they were needing in the constant watch rooms, that's where they need to be. You've got the hidden areas within a room, and the doors need to be locked on the wings. So I think that would be an issue if you needed somebody on a constant watch on a wing. Just because they are on a constant watch on E-wing also didn't mean to say they had to be behind that door. If they wanted to go to the library, they could be taken to the library with that officer with them, so they could still go to places whilst on constant watch.
Was E-wing regarded as a sort of informal segregation away from the wing? So not under the formal ways of Rule 40 and Rule 42, but informally taking them away from the normal residential wings?
I think the officers often, if they knew that somebody had stated that they weren't keen to go on their flight, then sometimes they felt it would be easier to remove from a smaller area than to have to, if their flight was at a time when it's normal unlock, rather than having to close down a whole wing to get that one gentleman out, it may be easier to take from a smaller wing.
And in relation to those who were vulnerable, it was used as to bring them away from the larger wing.
That's right.
And the greater number of detainees
Yes.
to a smaller environment.
For the calmer wing.
For the calmer wing. Force would sometimes need to be used to move someone onto E-wing, is that right?
Yes.
And that occurred with those not just who were deliberately trying to refuse their removal, but also with vulnerable people who were at risk of self-harm.
Yes.
And was force also used more frequently on E-wing than the other wings, given it was used to effect the removal of those who didn't want to be removed?
It was probably, yes, looking back at it.
Did you think mixing these two groups of people on E-wing was appropriate?
It's not appropriate to mix vulnerables with people that are then refractory as well. Sometimes it is your space available. If you've got a lot of refractories and they are extremely refractory, they'd have been in the CSU area.
I see. I'd just like to look at the witness statement of Dr. Rachel Bingham, who is a doctor at Medical Justice, and it's paragraph 157, which is at BHM 4033, and then at page 62. It's on the list. I'm sorry, do you not have the document? I'll maybe just read it out then. Dr. Bingham says, and you can follow it in your bundle, it's at tab 13 for the witness and for you, Chair. It says there is considerable clinical literature on the adverse mental health effects of physical isolation, particularly in respect of those who suffer from pre-existing mental health conditions or histories of trauma. She states that she's reviewed the literature and goes on, segregation has been associated with worsening symptoms of depression, severe anxiety, psychotic symptoms and exacerbation of post-traumatic stress disorder. Suicidal thoughts and risk of suicide are also increased. In the context of asylum seekers suffering from PTSD, for instance, it can precipitate or intensify the traumatic memories or flashbacks of their past mistreatment and increase their feelings of powerlessness. Were you aware of that type of research in general terms?
I was aware of research, and that's why we've actually looked at, because they're on constant watch, it doesn't mean to say that they are stuck behind that door now. And we are moving them, but if they want to go to the gym, if they want to go out to the library, they can go to those areas as well.
What about at the time in 2017?
I think then it was probably more so that they were behind their doors.
And do you agree with what Dr. Bingham says there?
Yes, that's why we've changed things.
And is that something you observed at the time in detained people held on E-wing due to mental health issues or suicide risk, that they tended to deteriorate?
Some did, not all of them, some did.
Dr. Bingham goes on at paragraph 157 still, it is accordingly imperative that healthcare discharges its safeguarding role diligently in the context of assessing and monitoring whether there are any clinical contraindications to the use or continuation of segregation. Do you agree with that?
Yes.
At paragraph 158, Dr. Bingham says that she notes, however, a recurrent pattern that emerges on the available evidence is the use of segregation, both under the Rule 40 and 42 safeguards, and held on E-wing as a mechanism to manage detainees suffering from mental illness or at risk of suicide and self-harm. Well, you'd agree with that as well, given what you've just told me.
That's right, yes.
Dr. Bingham concludes that effectively this was a failure of healthcare in those cases to properly identify and escalate clinical concerns over a detainee's unsuitability for segregation. And she says the primary purpose of segregation within this context is as a means to contain the distressed and high-risk behaviours associated with mental illness, such as self-harm or suicidality, rather than to seek to provide any form of enhanced safeguarding or clinical treatment for the vulnerable detainees. It's important to be clear that as it is detrimental to mental health overall, the segregation of detainees who are at risk of self-harm cannot be viewed as therapeutic. Would you agree that housing those types of detained persons on E-wing was to manage distressed behaviour, including self-harm and suicidal ideation?
Yes, it was.
And it certainly wasn't for the primary purpose of providing treatment.
No.
It's not an inpatient
No,
unit.
we don't have any inpatients.
Do you agree that it's also an important role of healthcare staff to identify and escalate any clinical concerns over the suitability for someone to be housed on E-wing in segregation?
Yes, and we review everybody.
Do you have any comment on Dr. Bingham's view that there was a failure of healthcare staff to identify concerns about unsuitability for detention on E-wing?
I don't think so, because for healthcare, it is looking at the risks for the patient. So on a wing where it's fully operational, that would not be suitable for them either. That would be too noisy for them, for mental health. So again, bringing them to E-wing, it was the best environment for them to be in.
Calmer, as you said.
Exactly.
Except when there were violent or refractory
That's
detainees
correct.
or those resisting their removal.
That's correct.
You say healthcare would visit detainees a minimum of once a day, including a GP, but from Dr. Uzarali's statement, he says he has no knowledge of how healthcare staff treat or monitor detainees in E-wing. Can you explain the discrepancy between those two?
He does come down to healthcare. He does come down to E-wing to visit them on a daily basis, but I don't think he's fully aware of what else we do within our role of healthcare.
I see. Well, we can ask him.
Okay.
Was the management of detained persons on E-wing driven primarily by custody staff? You
Yes.
mentioned visiting, but it would be those who were managing them.
Yes.
And that was the case even though these were highly vulnerable people with clinical needs.
That's correct.
Was any clinical risk assessment carried out prior to locating a vulnerable detainee on E-wing?
If they're on an ACDT, we would have had the input within the ACDT document. We're there for every ACDT review.
And if they weren't on an
And
ACDT?
if they're not on an ACDT, if they're under Rule 40 or Rule 42, we assess every single person that is placed on Rule 40 or 42, so that's within the CSU, but not necessarily for a basic vulnerability.
I see. In relation to then Rules 40 and 42, at paragraph 97, you say that you think someone would be moved to the CSU to maintain order in the centre. So do you think you have a full understanding of the criteria that are applied to remove someone under Rules 40 and 42?
Yes.
And just explain to me briefly then what those rules do.
So Rule 40 is to removal from association due to behaviour or safety within the centre. Rule 42 is somebody that's being more refractory, maybe on a dirty protest as well. And that's for a much shorter time that anybody would be placed on a Rule 42.
And as you've said, in 2017, those rules were sometimes used on detainees who had mental illness or who were self-harming or had suicide risks.
Yes.
Was it only GPs who made assessments of suitability for segregation, or did nurses do so as well?
Nurses would as well.
How do you check whether someone is suitable to be on CSU?
Looking at their background, looking at their mental health, their medical records to see if there is any issues behind them, and how they are at that present time.
So would an assessment be made of them?
Yes.
And would that be a clinical assessment of their physical and mental health?
Depending on how refractory they are at the time, because you may not be able to get as close. That might be part of the assessment, will be that you wouldn't be able to get there.
Do you accept that segregation should be used as a last resort?
Totally.
If someone's behaviour due to their underlying mental illness has become such that they need to be segregated, does that suggest that they've become very unwell?
Yes.
From a healthcare perspective, that should then identify the need for either a Rule 35.1 report or a Rule 35.2 report from a GP, shouldn't it?
The Rule 35.2s is for if they are suicidal.
Yes.
If they've got suicidal thoughts.
And Rule 35.1?
One is for medical conditions.
For medical conditions?
Yes.
Well, we'll come to that in a bit more detail in a moment. We know that in the relevant period in 2017, there were very few Rule 35.1 reports done, and we know that there were no Rule 35.2 reports at all in that period, indeed, I think for the entirety of 2017. Does that indicate then a failure in the management of those safeguards for vulnerable detainees?
I don't think so, because for Rule 35.1s, I did look at, because I covered the IRC forum for all of the other IRCs as well, we talked about it in quite depth at the IRC forums, and this was over all of the IRCs, it was the same figures. So we looked at ways that we could actually challenge this. So I did design the Rule 35.2 pathway,
Yes.
of which I think is in the bundle. And that was to actually safeguard and to actually to ensure that we were capturing everybody that had got any self-harm risks. A lot of the GPs felt for the Rule 35.1 that there was often a delay in the response because it could take up to 48 hours for a response to come back from Home Office. So therefore, by writing a Part C, they sometimes felt, and contacting Home Office, they would often get a faster response. And then patient could maybe released or put in, appropriately moved by that Part C.
I see. Just looking at, then we'll come a bit, in a moment to some parts of what you've mentioned, the Rule 35.2 pathway in a moment. I just want to look at detainees' access to healthcare. And you set this out to some extent at paragraph 79 of your statement, and you say that primary healthcare services provided at Brookhouse included access to a GP who is on site 7 days a week, physical health nurses, opticians and dentists. How would a detained person access a GP?
So we had the open triage clinic that was available 7 days a week. They would come in and see a nurse first, and then state that they'd request to see a GP and would make the appropriate appointment. And that would generally be the following day.
And that's routine sorts of GP appointments that are irrespective of the assessment under Rule 34,
Yes.
is that right? Were there delays in obtaining those types of GP appointments at all in the relevant period?
No, I mean only if the the clinic had got filled for the following day, he'd be posted to the next one. But we'd always keep 2 what we call embargoed slots. So if there was any emergency appointments came up, they would always be seen on that same day.
And you also deal with mental health services, which are provided by the registered mental health nurses in the first instance.
That's
is that
correct.
Right? How would a detained person access a mental health nurse?
So they can be made direct referrals from either the registered nurses, the GPs would also do direct referrals, and officers have done as well.
You talk about registered mental health nurses providing talking therapy groups and psychology groups. What type of talking therapies and psychology groups were provided?
Psychology group we had actually subcontracted in from a local provider. They'd come once a week and do group sessions for people.
And what type of psychology?
Coping skills. It was more the coping skills, a low level.
And the talking therapy?
Talking therapy was more of a one-to-one basis, and that was, a lot of it was low level talking therapy, coping skills again, how to cope with detention and
were any of them
removals.
Yes. Were any of them trauma based?
No.
You say that registered mental health nurses were also involved in ACDT reviews and Rule 40 and 42
Yes.
reviews. What was their role in those types of reviews?
For the ACDTs, there'd be a key participant. They'd be within the whole team of the review, and their points would be asked on every time as to how the patient was at the time.
So they'd provide clinical information.
Yes.
Would they
within the team? So it would be talked about. You've got the patient there as well at the same time. So it would be a joint multidisciplinary team meeting.
And would they provide a view on their risks, for example,
Yes.
of self-harm and suicide?
Yes.
And in Rule 40 and 42 reviews?
Again, that is looking at their suitability for maintaining in Rule 40, 42.
At paragraph 43 of your second statement, which is at tab 2 if you would like to look at it, you deal with what happened when a detained person didn't attend a medical appointment. And you say that if they had a known medical condition or were on medication, they would be followed up.
Yeah.
And if they did not have a known medical condition or were not on medication, you wouldn't follow them up, as it's their right to choose whether to attend the appointment or not. So did that mean that where there was known medical condition or medication, you would gain that information from the medical records?
They'd have had that we'd have worked that out from the initial health screening from the nurse on arrival to know that they've got no known medical condition, no medication that they're on. But
And
they'd
so-
also be given a leaflet to tell them how to access healthcare at any point.
I see. And what were the processes for following up those who didn't attend? What would actually happen?
We'd actually go to the wings, find them if we could, and rebook the appointment for them.
And were there any processes in place to check why someone had not attended a medical appointment, particularly perhaps mental health appointments, where there wasn't a known medical condition or medication involved?
I mean, if they got mental health issues, we'd class that as a medical condition, so that would have been we would be following those through if they got a known mental health condition behind them. But
What if it wasn't a diagnosed medical condition? What if they were simply vulnerable?
We generally would wait to see if they had come up to the wing. We'd see if they've got any reports from the wing. Majority were coming through were fit young men, and their first priority that first 24 hours was to contact the solicitors, and to see healthcare was not their priority.
What about when there were other medical appointments that had been made for them, so not in that initial period, but later, when those appointments were missed and there were requests from the wing, what was the process then?
We did always follow up. If they got appointments that they weren't attending, we'd find out why they were not attending.
And how would you do that?
Go to the wings, see if we could chase them to see whereabouts they were. Sometimes it is that they've got a visit that day, they've got the gym that they'd like to go to instead. So maybe it's a case we need to change the time of the appointments to fit in with what they need to.
Was there any consideration or exploration of the detained person's mental capacity to make those decisions, or was it still regarded as their choice?
At that time, it would be at their choice.
was there any consideration given to that someone might be so unwell they're unable to make those decisions about attending appointments or otherwise?
If we've got to that stage, we are involved because the officers would have alerted us as well. I do an induction talk to the officers, and the one thing I always say to the officers is that they see them more than we do. So if they do have any concerns about anybody, how they're interacting, to raise to us, it's called one of the red flags, and early indications is far better than treating at a later stage.
So you're saying that as far as you are concerned, on every occasion, those missed appointments would be followed up?
I do think there may have been one or two that haven't been. I can't say specifically the number that have not been followed up.
But you accept that some may have slipped through the
Yes.
cracks. Yes, if we could look at BHM 4042, please. Paragraph 42, it's page 12. So this I'm looking at is a witness statement that deals with a case of D1275, and in relation to this particular detained person, he missed 13 appointments at Brookhouse in 2017 for mental health assessment, and what happened was that he was discharged from the caseload on a number of occasions because of a failure to attend those appointments. And on the 22nd of June, a security information report from the wing noted that he may not have capacity to understand appointments with doctors and attend them. He was later diagnosed with schizoaffective disorder and was assessed to have no capacity to make those decisions, and after he was released he was hospitalised under the Mental Health Act and treated for several months. It appears that this may be one of the cases, at least, where it wasn't followed up, that the reasons why he had missed so many appointments. Would you agree?
Yes, I mean, the mental health team generally did go to the wings to check why people hadn't attended. I can't comment as to why they didn't do this one.
But you agree they should have done?
Totally, yes.
And should they have, at that time, assessed whether he had the mental capacity
Yes.
to make those decisions?
Yes.
It seems that the only action taken was to discharge him from the caseload. That shouldn't have happened.
No.
Are security information reports generally read by healthcare staff?
Only if there is a reason to come back to us. So it goes directly to security. If they feel that there is a need for healthcare to be informed, then they send us that part of the security information form. They wouldn't send us the whole form.
No, sure. But would you have expected this one, given what it says about mental capacity and
Definitely.
understanding about medical appointments,
Yes.
to have come to you? It's of concern that it doesn't appear to have done,
That's
isn't
right.
it?
Yes.
And that appears to be a serious omission in his case, because the system operating to safeguard him failed. All right. We'll move on. What's the time? We'll just go a little bit longer if that's all right with everyone. Yes, so at paragraph 108 of your first witness statement, you mention attending several individuals in 2017 who had a problem with spice, who were intoxicated and needed a medical attendance. In your view, was there any possible link between the use of drugs such as spice in Brookhouse and a detained person's mental ill health?
There was. It certainly did affect their mental health, yes.
And not just that spice affected their mental health, but that their mental health may lead them to take spice.
Yes. And I think some of them were used. Some of the gentlemen that got mental health issues may well have been used as guinea pigs for trial of spice as well.
Yes. It wasn't practice to undertake a mental health assessment on a detained person regarding their recurring use of spice. Is that right?
That's correct, yes.
Why not, given what you've just told me about the link with their mental health?
I think we were looking more at the drug-seeking side first, so they would be put through for Ford Trust would have looked at them for their substance misuse, and if they felt there was a need within mental health, they'd refer them back as well.
I see. It wasn't an assumption that it was their choice whether to take spice or not.
No.
In effect, showing that they would an attitude that they were doing this to themselves.
No.
At paragraph 110 of your statement, you say that low-level mental health issues, which you've mentioned before in your evidence, are dealt with by the registered mental health nurses, and you give an example of stress-related problems.
Yes.
You say that if a resident had a more serious mental health problem, they might be managed by weekly psychiatric appointments or reviews, reviewing their medication. Long-standing mental health conditions, you tell us, are also managed by registered mental health nurses. Is that right?
That's correct.
And is that still the case in Brookhouse?
Yes, that is the case.
At paragraph 86, you say that the most significant health problem experienced by detainees in 2017 related to stress.
Yes.
And that there was a lot of low-level mental health issues stemming from stress.
Yes, that's correct.
Was it also your experience, though, that a high proportion of immigration detainees have clinically significant levels of depression and PTSD and anxiety?
Quite a few do, yes.
And medical research tends to support that. PTSD is particularly prevalent in the refugee or asylum seeker population. Would you agree with that?
Yes.
It's therefore important, as we've briefly touched on in relation to your training, to be in a position to identify trauma symptoms, isn't it? At least to ensure that your staff, the nursing staff, are referring those detainees in that situation to a GP to carry out an assessment.
Yes.
Or indeed, I suppose, to a psychiatrist in relation to treatment.
Yes.
But in particular, in relation to a GP carrying out an assessment, it's important because it's relevant to identifying the impact of detention upon that person. Is that right?
Yes.
It's important because identifying people who are not suitable for detention is part of that system, of that process. A GP needs to assess under Rule 35.
Yes.
You don't seem to recognise in that paragraph I've just referred you to that PTSD was really a prevailing mental disorder amongst detainees, but you do accept that.
I do, yes.
Are you confident that you and your staff in 2017 were able to identify symptoms of trauma?
Probably not enough, no.
Not enough.
And that's due to the fact there isn't enough actual specific training on PTSD for our nursing team.
Or indeed on torture awareness?
Yes.
Or on Rule 35?
Yes, and that is still ongoing.
And that's still ongoing. It wasn't a downplaying of the severity of mental
Definitely
illness
not.
as stress?
Definitely not.
No.
I mean, mental health for the detainees has always been very high for the simple fact that in a prison they've got an end of sentence. In an immigration removal centre, there often isn't an end of time, so that's what can often play on their mental health.
Yes. And because not recognising that symptoms may be due to PTSD would affect the ability of healthcare staff to keep detainees safe, wouldn't it?
Yes.
Because they wouldn't be referring them for Rule 35 reports.
Mm-hmm. That's correct.
And that plays a key role, that healthcare role of your nursing staff plays a key role in identifying those who are vulnerable and who, therefore, the Home Office needs to know about
Yes.
to consider in its detention decisions.
That's correct.
In fact, a little early, Chair, that may be just an appropriate pause for a break.
That's fine, Miss.
So I suggest 15 minutes. Perhaps we can say 20 past 3.
That's fine.
Thank you.
Return at 3:20. Thank you.
just the sort of thing that people are used to.
Thank you very much. Please take a seat.
Thank you.
Thank you, Ms. Simcock.
Ms Calvert, at paragraph 110 of your statement, you say that on occasions detained persons would need to be sent out to hospital. That was if they had become so unwell that they needed inpatient psychiatric treatment in a mental health hospital. Is that right?
Or physical care, yes.
Or physical care. You say that in extreme circumstances you can get people released if we think their mental health is so seriously affected by detention. What do you mean by extreme circumstances?
We've had a couple of patients that we have had released, but they've actually been released and sent under Section 2 from hospital, but they felt that they didn't need to be detained. Whereas normally if we are sectioning people whilst they're with us, they'd go under a Section 48, which means that they will remain detained.
I see. So you're talking about Section 2 of the Mental Health Act. So the extreme circumstances are when they're so unwell they need inpatient psychiatric treatment.
That's correct, yes.
And what do you mean by so seriously affected by detention? Just that they're very unwell?
That's right, yes.
And the mechanism for doing that then was transfer under the Mental Health Act?
That's correct.
And so you're not here talking about Rule 35?
No.
I see, thank you for clarifying. You also say that the difficulty with mental health treatment in a detention setting is that you cannot provide long-term treatment or cognitive behavioural therapy, CBT, as it's not safe for the resident for us to open up wounds and then leave them unhealed.
That's correct.
And that this can be very frustrating for the practitioner. By opening up old wounds, do you mean exploring a history of trauma?
Yes, and if you get to the point of extreme and then they're released, that's very dangerous for them.
And that might include being a victim of torture?
Totally.
And by leaving them unhealed, you mean that without the full range of treatment necessary for them likely to be able to recover?
Yes, and there'd be a serious risk of self-harm if they're going out in that extreme point of, if they've got to that point of opening up, but then nothing else is going to happen, that's when they're at a high risk.
I see. In terms of access to care and treatment, you're aware of the principle that detained persons in an immigration centre should receive equivalent care to those patients in the community.
Yes.
At paragraph 111 of your statement, you say that residents have far better access to mental health care than they would in the community. In what sense do
I think
they
I
have
was talking
better
about in total care, so not just mental health. It was a case of we can give them GP appointments within the following day. And I know the majority of us can't get a GP appointment that quickly and haven't done for many a year. But also they've got access to the dentist, to the opticians and our primary care aspects that we do as well on site.
So you were more there talking about physical
healthcare, yes.
Because, as you've just said, they certainly don't have access to the full range of psychiatric
No.
treatment or CBT.
No.
I see. In Professor Katona statement at BHM 4030 at page 9, Professor Katona, as I'm sure you know, is the Medical and Research Director of the Helen Bamber Foundation and a Professor of Psychiatry. And the Helen Bamber Foundation is a charity which helps survivors of torture and trafficking. He mentions that detention centres are not appropriate therapeutic environments to promote recovery from mental ill health due to the nature of the environment and the lack of specialist mental health treatment resources. Presumably
That's
you'd agree
correct.
with that?
Yes.
He also says that the current ethos of mental health services is on recovery and community rehabilitation, and that this can't be provided in a detention centre. Do you agree with that
that's
as well?
correct, yes.
He then says at paragraph 19 of his statement that it was therefore crucial that clinical and other staff working in detention centres were given adequate training and support to identify mental disorder when it does arise or deteriorates significantly in a detention centre, and clear guidelines on how to manage this appropriately and to link up with existing local mental health provision outside the detention centre. And this should include specific attention to appropriate monitoring and management of risk. Do you agree with that suggestion?
Yes, I mean, we did have good links with our local mental health provider.
Do you think that was provided in Brookhouse in 2017?
We had the links to the mental health team, It wasn't as strong as it was. We've now changed providers.
And what about adequate training and support to identify mental disorder when it does arise or deteriorate?
We didn't have enough at that point.
And what about now?
Now we're with PPG. We've got further mental health training within our mandatory training. We've also got within our mental health team coming in, we've got psychologists coming in to work on site and assistant psychologists. So the whole mental health team is expanding. So we're going to have a lot more services available for people.
I see. At paragraph 113, and you've dealt with this briefly in your evidence before the break, you say that there were sometimes detained persons on a constant watch due to suicide risk. And you again referred to those being managed on E-wing in the rooms used for a constant watch. And I think you agreed with me also that self-harm in the past is a risk factor for suicide.
Yes.
I think you also mentioned in your statement that your nursing team would be working to the appropriate NICE guidelines.
That's correct.
NICE being the National Institute for Clinical Excellence. The NICE guidance on self-harm and short-term management and prevention of recurrence stresses the important role that primary care plays in assessment and treatment of people who self-harm. Would you agree that primary care, so nurses,
Yes.
Including nurses, play an important role in
Yes,
that?
we do.
When an individual presents following an episode of self-harm, healthcare professionals should urgently establish the likely risk and the person's emotional and mental state. Would you agree that where someone's self-harmed, there should be an assessment of someone's physical risk and emotional and mental state?
Yes, and we generally, that anybody that has self-harmed, they will be, if they haven't been referred to the mental health team before, will definitely be referred to at that point.
And do you think that your team were carrying out those types of assessment when someone was referred to them for self-harm?
Yes, it wasn't an in-depth assessment, but it was an assessment, and they were referred to mental health team.
You've said that a suicidal risk would trigger an ACDT and a constant watch. Does that mean that if someone is on an ACDT on a constant watch, it's likely that they are at high risk of suicide?
Yes.
We'll come to Rule 35 in particular in some detail in a moment, but suicidal intentions should also trigger a Rule 35-2 report, shouldn't it? And so in the case where it's the nurse who's aware of suicidal intentions, that should trigger a referral to a GP, shouldn't it?
Yes. If the self-harm is for suicidal awareness. Some of our self-harms is not for suicide intentions.
Indeed,
But
where
it's
someone,
difficult to assess.
yes, but where someone has been placed on an ACDT
Yes.
for a constant watch, for
Yes,
example,
definitely.
then it should trigger
Yes.
consideration of Rule 35-2.
Mm-hmm.
You mentioned that GPs perhaps weren't always doing Rule 35-2 reports. In fact, we know they weren't in
Yes.
2017. And you mentioned a Part C as an alternative route.
That's more, the Part C was more for the medical condition, to alert the Home Office that somebody has a medical condition that would be not suitable for them to remain in detention.
Do you think that doctors were doing Part Cs to notify the Home Office instead of Rule 35-2 reports, given there are no for 35-2
I'm
reports?
not so much for the Rule 35-2s, no.
And indeed that would be inappropriate, wouldn't it?
Yes.
Because a Part C doesn't trigger a review of detention, which Rule 35-2 does.
That's correct.
Would self-harm trigger an assessment to determine whether more urgent care is needed?
Yes.
And was that routinely happening in those assessments, that not just about Rule 35, but actual the care in
Yes,
Brookhouse of the
if
that
anybody
detainee?
did self-harm then, and were on an open ACDT, then that may trigger an earlier review than their next planned review. They may do an emergency case review at that stage if they'd just self-harmed.
And was
And that
that
would be a multidisciplinary team as well.
was that up to the individual nurse, or was it a system operating to protect those detainees?
That would be the nurse and the officers as well, so it would be more of a system.
At paragraph 68 of her statement, Dr. Bingham sets out, it's at page 23 of BHM 4033. She sets out that she is aware, in working for medical justice, of several cases where detainees were noted as being advised by a nurse to use an elastic band around their wrist to help with thoughts of self-harming. And she says this is at best a harm reduction approach through a less dangerous means of inflicting pain. It does not address or treat the underlying cause, be it distress, unmanageable symptoms, lack of other coping mechanism, or other mental health issues. To provide this without other intervention to mitigate the distress shows a focus purely on risk management and not on therapeutic care. In my view, it should not be used as a substitute for exploration of the underlying causes and exacerbating or perpetuating factors, and for therapeutic intervention to reduce the person's risk in the longer term. So first of all, are you aware of detained persons being advised in this way in how to cope with thoughts of self-harm?
The mental health team will have actually been assessing them at the time, and it was the mental health team that did issue out elastic bands to a couple of residents.
So you were aware of it?
Yes.
And was that in 2017, or is that ongoing as well?
I think that was 2017. I don't believe it's ongoing at the moment.
Do you agree with Dr. Bingham that that shouldn't be used as a method on its own?
And it wasn't at the time used as a method on its own. They were being reviewed at the time as well by the mental health team.
So there should be further intervention
Yes.
to mitigate distress?
Yes.
Do you think that there was?
Yes, I believe there was.
The underlying causes and the triggers and exacerbating factors should also be explored.
Yes.
Do you think that was happening?
Yes, I mean, a lot of our triggers are the fact that they've got a pending flight coming up. And we can't always be the ones that say stop the flight.
No, of course.
That's not for healthcare to do, unfortunately.
Do you agree there should be some further therapeutic intervention to reduce the risk in the longer term?
Yes.
And what sort of therapeutic interventions could your team provide?
Difficult for us at the time. We didn't have many other services to provide, so it was one-to-one therapies that they were dealing with. The mental health nurse will be able to say more of the care that they gave. Now we do have a pending sort of the psychologist team coming in and the assistant psychologist team coming in. They will be able to give a lot more support.
I see. Can we look at, please, the management of adults at risk in immigration detention policy? It's CJS 30731. Marvellous. And if we could look, please, at page 5. You say in your witness statement at paragraph 20 that you describe this policy as a Home Office document, which we see that it is, and that G4S Healthcare didn't have its own equivalent policy. But it's right that this is a policy that you and your healthcare staff were expected to apply,
Yes.
wasn't it, even though it was a
That's
Home
correct.
Office document?
Yes.
And indeed we can see at paragraphs 1 and 3 that it refers specifically to healthcare staff and then also to all staff. Because it's important to recognise that this is the statutory framework governing the safeguards against detaining vulnerable people.
That's correct.
What is your understanding of the definition of an adult at risk?
Definition of somebody at risk would be somebody that is vulnerable or may actually have cause for concern whilst they're in a detention estate.
And if we look at paragraphs 5 to 8 of the policy, so starting at the bottom there of page 5, if they declare that they're suffering from a condition or have experienced a traumatic event such as trafficking, torture or sexual violence that would be likely to render them particularly vulnerable to harm if they're placed in detention or remain in detention.
That's correct.
That would classify someone as an adult
Yes.
at risk. And over the page, if a case owner considering or reviewing detention becomes aware of medical or other professional evidence or observational evidence which indicates that an individual is suffering from a condition or has a traumatic event, that would be likely to render them particularly vulnerable to harm if they are placed in detention or remain in detention. In these circumstances, the individual will be considered as an adult at risk, whether or not the individual has highlighted this themselves.
That's correct.
And underneath there are several things listed at paragraph 7, and we see victim of torture there, for example. We see suffering from a mental health condition or impairment, being a victim of various different things, suffering from PTSD also, suffering from a serious physical disability, and some physical health conditions and age. In relation to your role as head of healthcare, how were you instructing or guiding your staff to apply this policy?
So, as I said earlier, they actually had training from Home Office on this policy, of which I managed to get the majority of the staff on it. They were also all sent the policy with clear instructions of what to raise as a vulnerable person. And a Part C would be opened if anybody came in claiming any of those conditions or any of those reasons. And then that will be sent to Home Office if they weren't already declared as an adult at risk.
But the policy serves to work in conjunction with Rule 35, doesn't it?
Yes.
Whereas Part C doesn't prompt a review of detention
No,
in the
Part
same way
C
that
was
35.
to do that alert to the case owners, and that's what we were advised by Home Office to do, was to do the Part C. If anybody got a claimed medical condition or suffered torture, they'd have a Part C completed.
I see. In relation to your understanding of the different levels, if we can look at, please, INQ 30112 at page 46. So this is the report of Dr. Hard, who is the expert instructed by the inquiry in clinical matters. He comments, I might be on the wrong page, 47, I'm sorry. There we go. In that third bullet point, Dr. Hard comments on an entry you made in the records of D801 in March 2017, and you state there that he states there that you provided an IS 911RA Part C. That's what you've just referred to.
That's correct, yes.
So that's not a Rule 35.
No.
You as a nurse can't do
No,
Rule
that's
35
correct.
reports. Why did you provide a Part C instead of referring to a GP for a Rule 35 report?
That was a notification rather than the actual referral. So this is a gentleman that's come back that was due to be going for a section. So, and then the psychiatrist actually revoked the section.
Yes.
So therefore it was a notification. It wasn't, he'd actually improved, and it was immediate care to be put onto his SID records.
I see. And what you say there is he's had his mental health section revoked and is no longer under Section 48, as you've just said. He remains under the psychiatrist care at Brookhouse, or if released under the care of the community, he remains as an adult at risk, level 2/3. Dr. Hard points out that the adults at risk policy doesn't contain a category of 2/3. One is either one or the other. Or
So as in
level one.
healthcare, we're not allowed to actually state what levels they're at. The Home Office have stated just before that we're not able to stipulate the level. So therefore we can put, we recommend a level. So putting 2 to stroke 3 would be for them to, the caseworker would actually make that decision.
I see. So in referring the case to the Home Office, you were instructed by the Home Office not to record what your view of the level of risk was.
So we can put, we recommend, but we can't state what it is. That's for the actual caseworker to make the final decision.
And who at the Home Office instructed you?
That was in the policy team when we had our first training.
I see. And when was that? Before 2017?
Yes.
Did you understand the difference between levels 2 and 3?
Yes, I mean, it is fairly blurred. The level 2 is a very vast level. It encapsulates an awful lot of people. 3 is people that are unfit to be in detention.
So level 2 indicates there's independent evidence such as a medical report.
Yes.
Or a Rule 35 report that someone is at risk.
Yes.
Which might include those factors we've just been through, such
That's
as being
correct.
a victim of torture or various other different things,
Yes.
such as a mental health condition. Level 3 indicates there's independent evidence such as a medical report or a Rule 35 report that someone is at risk and also that detention is likely to cause them harm.
That's correct.
So they're unfit to be in detention.
That's correct.
So describing someone as level 2 or 3 is somewhat confusing.
Yes.
In
I think the fact that
relation-
somebody requires to be sectioned means that they are fairly unwell.
Yes, indeed. Dr. Hard comments that in D801's case, we know that he arrived in Brookhouse on the 1st of March 2017 and an ACDT was opened in relation to him due to a risk of self-harm, and he reported he was a victim of torture. He didn't attend an appointment with a GP and there wasn't any follow-up, but he did later see Dr. Belder and Dr. Chowdhury, and the plan, as you said, was to transfer him to hospital because he was so unwell.
That's correct.
That didn't happen. In fact, the transfer was revoked, and he was seen by Dr. Belder on the 9th of March. On the 3rd of April, Dr. Chowdhury completed a Rule 35-1 report dealing with his deterioration in detention.
Mm-hmm.
That seems to be a significant delay in carrying out a Rule 35-1 report of something in the order of a month. And Dr. Hard comments that it should have happened earlier. Do you
I
agree with that?
Yes.
Do you have any explanation as to how that happened?
I can't recall, unfortunately.
Right, moving on then, you can take that down, thank you. At paragraph 81 of your statement, you say that everyone also has to be seen by the GP within 24 hours of arrival at Brookhouse. That's in addition to the health screen that you've talked about that the nurse carries out.
That's correct,
or
yes.
Healthcare assistant. That GP assessment is the assessment under Rule 34, is it?
That's correct, yes.
It's not some other routine GP appointment for a different purpose.
No, it's new arrival Rule 34 appointments.
You don't specifically mention that at paragraph 81. Was there a reason for that?
No.
Oversight?
Yes, sorry.
And what is your understanding of the primary purpose of Rule 34?
To check the vulnerabilities and awareness of any medical conditions that may be coming into the centre.
In your interview with Kate Lampard and Ed Marsden for the Verita report, you described this initial GP appointment as a 5-minute appointment. Is
That's
that right?
correct, yeah.
Was that in 2017 or is that still the case?
They're 10-minute appointments now.
So 5 minutes in 2017, 10 minutes now.
Yeah.
In relation to Rule 34, and perhaps we can have it up on screen, it's CJS 006120 at page 11, please. So the detention centre rules, page 11 should be Rule 34, and if we could just zoom in slightly on Rule 34, it's quite small. So there we have the wording of the rule, and it says every detained person shall be given a physical and mental examination by the medical practitioner or another registered medical practitioner in accordance with Rules 33 within 24 hours of his admission to the detention centre. And that's that initial appointment you're talking about.
That's correct, yes.
So the rule requires a full assessment, both a physical and mental examination by a GP of everyone who arrives in the
That's
centre.
correct.
It's specifically not only if a detained person requests it.
No.
Is that right?
They're all given an appointment.
And it's not only if the nurse screening the detained person assesses that they need to be seen.
No.
It's
Everybody.
mandatory.
And that's
Is-
why we do get a lot of DNAs on that one, because the residents don't want to attend.
Yes. Is it realistically possible to adequately do a physical and mental state examination in a 5-minute appointment?
And that's why they do, it is a very brief one. If anybody does have any conditions, then they will make a further appointment of a longer time.
But if it's not possible to adequately do a mental and physical examination in that initial appointment, it can't properly be regarded as the Rule 34 assessment, can it, given that's what the rule requires?
This is the same as it's been throughout all of the other IRCs as well. So we've reviewed it. When you have vast numbers coming in one day, you can't have 20-minute appointment for everybody, because the doctors would be there 24 hours a day.
No, understood, but just dealing with whether it reflects the requirement of the rule, it may not be possible to achieve that, but it doesn't reflect what the rule requires, does it?
No, it doesn't say the extent of the appointment. It doesn't say the extent of the medical and physical examination, which is why we do go, if anybody does have a condition, we'll make a further appointment for them.
I see. As we've dealt with briefly before, the first reception health screening, given it's carried out by a nurse, can't be regarded as the Rule 34 assessment, can it?
No.
Because it doesn't fulfil the requirements of the rule, being that a GP has to carry it out.
That's correct.
Could we just look at then CJS 006045, please, and at page 21. So this is the detainee reception and departures policy from G4S from 2017. And at page 21, there we go, it says underneath the bullet points that deal with the detention centre rules, the sentence that starts detainees, do you see that?
Yeah.
Yes, there we go, thank you. Detainees who have been seen by the triage nurse and require or request to see a doctor, subject to their consent, will be seen on his/her next visit. Detainees will see a doctor in any such event within 24 hours of admission. Does that suggest that a detained person will see a doctor within 24 hours, firstly if a nurse thinks they require it, or secondly if they request it, as opposed to everyone having to see one?
So this wasn't a G4S health document, and this was actually, we do give every single person an appointment. So this states that people are requesting appointments, they don't request them, they are given an appointment.
So this doesn't adequately or accurately reflect either the rule or what was happening?
No.
At the very least, it's pretty confusing.
Yes.
Evidence, thank you, you can take that down. Evidence from medical justice suggests that they were aware from their casework that Rule 34 assessments were routinely not carried out within the first 24 hours of a detained person arriving in Brookhouse. Do you have any particular comment to make about that?
I think we do sometimes we have a large number come in, or if they've come in early hours of the morning, they may not get their appointment until the following day in the daytime, which could be just over the 24-hour period. But we carry out our audits to ensure that we've got everybody being seen.
So far as you are concerned, it was individual cases and
Yeah.
not a systemic issue?
No.
Is that the case even though there were these only very short appointments, which you've accepted would allow only for a limited examination? So could it be that there was a systemic issue in that certainly the detainees perhaps, but also medical justice were of the view that those initial appointments were being treated as a Rule 34 when actually there hadn't been an adequate examination?
I think there probably needs to be a further explanation from Home Office as to what the full extent they want from a Rule 34 appointment, because when you do have large numbers coming in of young fit people that a majority do get transferred from prisons, whereabouts they've had medical care, do they require to be seen by a GP at that point? Some certainly do, but I'm not sure everybody does on that first 24 hours.
I see. One reason it's important that it's done quickly is because in contrast to that screening with the nurse, it should involve that full examination, so may pick up something that a nurse hasn't. Would you agree with that?
Yeah.
And the importance of picking up physical conditions as well as mental health conditions is that they may require treatment.
Yes.
That's certainly one thing that's
Totally.
important. But it's also for picking up vulnerabilities, as you've said. So, for example, clinical concerns that someone may have been a victim of torture, may have PTSD, whose symptoms might be made worse by detention, may in another way be harmed by detention. That's right.
Yes.
So that assessment is important in allowing for consideration for a referral to be made for a Rule 35 report. Is that right?
Yes.
So, in other words, it's an important safeguard for vulnerable detained persons relating to whether they should be detained at all at the outset, isn't it?
Yes.
So if it's not being adequately done quickly, someone could be being detained when they really shouldn't be,
There is that possibility.
and may be harmed by that detention. Yes. Again, the evidence the inquiries received from medical justice suggest that they were aware that often the nurse screening was being treated as the Rule 34 assessment in breach of the rule. Do you have any comment upon that?
No, it's part of the Rule 34 because the Rule 34 states to be seen by a nurse within 2 hours,
And
but
then the doctor?
then also by the GP.
Oh, I see. As head of healthcare, then and now, are you satisfied with the guidance you were giving and are giving your staff about the purpose of that first health screening? Did your staff understand that wasn't the full assessment needed
Yes.
by a GP?
Yeah, and that's why we do give everybody a GP appointment.
So your evidence is that you were taking steps to ensure that every single detained person was seen by a GP for a Rule 34 assessment within
Yeah.
24 hours.
They were. Some do refuse to attend, but they are given that appointment.
And even if it's only for 5 minutes.
Yes.
In your Verita interview at page 5, you say that doctors' appointments are running 4 to 5 days, and you described that detained persons will see a nurse, are triaged, and if required, a doctor's appointment will be made. Are you there talking about other types
Routine
of GP?
appointments.
So not those under Rule 34?
No.
Excuse me. Again, evidence the inquiries received from medical justice suggests that Rule 35 referrals did not always happen, even when the nurse at screening had been given a history of torture by the detainee. Do you have any comment upon that?
I have found the occasions about nurses have missed making the appointment. I have gone back to them and asked them why. They are all told that they need to make the appointment. It is now a mandatory question. asking about torture, and if it prompts yes, then that there has a prompt come up to say make the appointment.
I see, but that wasn't a prompt in 2017. So do you think that if it wasn't happening in 2017, that was an individual problem or a systemic one?
I think it was a couple of individuals.
I see. Who were they?
It was a couple of the healthcare assistants, and that's why we did make sure that we got the general nurses checking through their screenings as well.
I see. So it was a problem of inexperience.
Yes.
And of inferior qualification and training. Nurses are trained to a higher level
yes.
than healthcare assistants.
Yeah.
So you are now satisfied as head of healthcare that your staff are correctly applying the adults at risk policy, in particular because of the prompts that you've talked about on the
yes.
system. What about training? Is further training given to them now than was available in 2017?
No, there is no further training available on the policy, so part of their induction will be to show them the policy and to talk them through it.
You say at paragraph 117 of your witness statement that a Rule 35 report is a report saying someone has suffered from torture, that's Rule 35.3, has a severe or unstable medical condition, which means they're not suitable for detention, that's Rule 35.1, or is severely suicidal and not suitable for detention, and that's Rule 35.2. Is that your understanding of Rule 35?
Yes.
And was it at the time?
Yes.
If we perhaps then just look at the wording of the rule, can we have on screen CJS 006120 at page 11 again, please? Thank you. And can we look at Rule 35, please? It's right in the middle. Fantastic. So we see there the first three subsections are the relevant ones we want to look at. And we see subsection 1 says the medical practitioner shall report to the manager on the case of any detained person whose health is likely to be injuriously affected by continued detention or any conditions of detention. And Rule 35.2 says the medical practitioner shall report to the manager on the case of any detained person he suspects of having suicidal intentions, and the detained person shall be placed under special observation. So looking first at Rule 35.1, the language of Rule 35.1 doesn't require a diagnosis of a medical condition, does it?
It doesn't there, but it does within the DSO of Rule 35, I believe.
So your understanding is that the Home Office document has put a gloss on the wording of the rule.
They've changed, with the torture definition has been changed numerous times as well, which has caused some confusion.
I see. And it doesn't require, in the wording of the rule, a medical condition of a particular level of severity or instability, does it?
No.
Contrary to what you say in your witness statement.
Apart from it says it's likely to be injurious, affected by continued detention. That's what I mean by severity.
I see. If someone has mental health problems, if Rule 35.1 worked it as you've set out in those two respects, it would require someone to become so unstable that detention has already actually harmed them, wouldn't it?
Yes.
Before considering release. And that's a very risky approach to take. Indeed, it could be dangerous because they could be harming themselves to an extent of attempting suicide, for example. Or they could be deteriorating in relation to their medical condition and their mental health in a way that just wouldn't have happened were they not in detention. In that sense, then, it would be the wrong approach to take, wouldn't it?
Yes, in that respect.
And it's certainly in breach of the wording of the rule.
Yes.
Is that something you, as head of healthcare, should understand?
Yes.
if we look at Rule 35.2, a GP is to do a Rule 35.2 report if he suspects that a detained person has suicidal intentions. Do you agree that a suspicion of suicidal intentions is a much lower threshold than the threshold you've used in your witness statement of severely suicidal?
Yes.
So it seems as though your understanding of the way these rules were to operate was inaccurate. Would you agree with that?
From what you said, yes.
In that, in particular, you seem to be setting a higher threshold than the wording of the rule for its operation.
Probably.
Again, that creates a potential problem, doesn't it? Particularly in your leadership role as head of healthcare, in that it's likely your staff are also applying a too high a threshold.
I mean, I've discussed the Rule 35.1s and Rule 35.2s at all of the IRC forums as well. This is throughout all of the IRCs. This is not just specific to Gatwick.
And so you were reassured that everyone else was doing it?
Yes, and it wasn't because I was leading. That was their understanding as well. We had GPs talking to us. We had Home Office officials there at it as well.
And in that forum, just describe to me what the purpose of the forum was.
It was to get uniformity across all of the IRCs. So we talk about all Home Office policies, any issues coming up that are any trends coming through for IRCs, but just to get some uniformity across all of the IRCs.
I see. And the Home Office were content with the thresholds that you were applying?
They were, and they've seen the pathway for Rule 35.2. They've seen that pathway, and they were happy with that pathway that I put in place.
We'll come to that
That's
in
fine.
just a moment. We will look at it,
That's fine.
I promise. But just staying with this point at the moment,
Mm-hmm.
so your understanding as being approved by other IRCs doing the same thing and the Home Office knowing that, was that you were setting a higher threshold than the rule actually required.
It wasn't me personally setting it. I think that was it was a general understanding that we all had
And that's
of
how
how
you
we
were-
interpreted it.
And that's how you were interpreting the rule.
Yes.
And so that, in practice, was what was happening.
Yes,
And amongst your staff as well.
yes,
But in order for a GP to consider making the report, a detained person has to be referred to them, don't they?
yes,
And that may be by your staff, by seeing a detained person in a variety of different situations, mightn't it? Not just a Rule 34 assessment.
no, that's correct.
So, for example, in mental health appointments with an RMN, in triaging for GP appointments,
Yes.
a nurse, yes, in ACDT reviews,
Yes,
or having been called as an emergency response to a particular situation, such as a self-harm attempt or suicide
Yes.
attempt.
and also multidisciplinary team meetings that we had. Any of those could bring up patients as well.
Food and fluid refusal observations,
Yes,
and Rule 40 or 42 reviews.
yes,
We know in 2017 that there were 8 Rule 35.1 reports and no Rule 35.2 reports at all, as we've mentioned previously. That also reflects, doesn't it, that a higher threshold than was appropriate was being applied.
that's correct.
And your explanation for the reason why there were only 8 Rule 35.1 reports and no Rule 35.2 reports was partly what you had gained in your knowledge and understanding from the IRC forum. Is that right?
Yes,
As approved by the Home Office, in your view.
that's correct.
Yes. And were also other mechanisms being used to notify the Home Office of concerns, such as the Part C you've mentioned?
Part C is talk about it within the adults at risk meetings. Anybody on those that was dealt with by Home Office, Health and G4S staff there as well.
Yes. But as we've established, Part C doesn't trigger a review of detention by the Home Office, does it?
No,
So as a safeguard, it's inferior than to Rule 35. You'd agree with that?
yes. The reason for the Rule 35.1s we found often for physical, but the delay sometimes for getting the response back from caseworkers Sometimes you want a more immediate action, hence why Part C has been completed.
And was your experience that Part Cs were responded to more quickly?
Yes.
And were they prompting, though, a review of detention?
Yes. Especially if the GP had actually written in there unfit to be detained.
And was that in relation to physical conditions primarily?
Generally physical.
I see. But Rule 35(1) isn't confined to physical conditions,
No.
is it? And it should be being used, and should have been used in 2017, to notify to the Home Office someone whose mental health was likely to be injuriously affected by continued detention, in accordance with the wording of the rule. And the rule says likely to be injuriously affected, not has been injuriously affected, doesn't it? So it's a risk assessment looking forwards, as well as assessing whether harm has already occurred. Is that right?
Yes.
Or at least it should have been.
Yes.
We know from the IMB reports, the inspections by the IMB in the months between April and from April to August, the relevant period, that there were 195 new ACDTs opened and a total of 248 ACDTs open. That suggests there should have been significantly more of both of these types of reports, doesn't it? Rule 35(1) and Rule 35(2).
If they are of suicide ideations, yes.
But, well, certainly Rule 35(2) for suicide, but in relation to Rule 35(1), that's just someone whose health is likely to be injuriously affected by continued detention. An ACDT suggests that there has been a concern about a risk of self-harm, doesn't it? Not just suicide.
Yeah.
So even if, which it's likely it isn't, but even if all of those ACDTs were purely in relation to self-harm only and not suicidal ideation, one would have expected significantly more Rule 35(1) reports, wouldn't one?
Yes.
That suggests that vulnerable detainees weren't being protected by the safeguards under this rule, doesn't it?
Yes.
Those safeguards failed.
That's correct.
Who is responsible for that, in your view?
Healthcare plus Home Office. I think there needs to be further training on Rule 35s
Yes.
because there is not that training out there for myself, for the GPs or anyone giving the specific.
Yes,
wording
Dr.
to
Hard
them.
agrees with you. Did you give any consideration at the time, in 2017, to the reasons you weren't seeing very many Rule 35(1)s or any Rule 35(2)s given that number of ACDTs?
I don't think so at that time.
No. Was there any monitoring by you as head of healthcare of these reports and the numbers that were written?
We have an audit that we do, collating the numbers that we do each month. I think my main priority was actually trying to push to get training,
see.
and I've pushed for that since before 2017 to get training,
And
I'm ongoing with pushing to get that training.
and who are you pushing and who did you
Home
push?
Office policy team.
I see. Anyone in particular at the Home Office policy team?
I've been through to all of them. It's through the IRC forum that we've gone through, trying to get further training developed. At one point it was a combined of Home Office and NHS England. Now I believe it's back to just Home Office.
So you certainly were then and are still pushing for training. Did you raise concerns about the numbers you were seeing, or was that not part of your consideration?
No. I looked at the quality of our Rule 35s as well, because in response to one of the HMIP reports, there was an issue about our quality.
Yes.
And with that, I actually I asked again if Home Office could tell me what a quality of a Rule 35 should be, and again they couldn't come back with what the quality of one would be.
I see.
So I then developed, along with my medical director at the time, I developed our own internal audit, going through, looking at the quality of them. And I shared that audit also with Home Office.
And what did your audit show?
There was some disparagement between different GPs. One wrote very little, one wrote a lot more. So we did a lot of review with the GPs and asked them to actually do peer-to-peer reviews as well.
I see. And did the Home Office ever raise with you the quality of Rule 35 reports they were receiving?
No.
They never came to you and said these aren't good enough.
Very occasionally you get one come back saying the GP didn't state if they were to be detained or what their thoughts were of detention at the end. That was a rare.
Sorry. It was rare.
Yes.
Did the Home Office ever raise with you a concern about the numbers of Rule 35 reports coming through under Rule 35.1 or Rule 35.2? Not at all?
No.
Have they ever raised that with you?
No.
In the entirety of the time you've been
Not
head of
that
healthcare?
I've been aware of.
It sounds as though you now consider the numbers. Is that right?
Yes, I mean,
in your audit process.
yes, we look at the numbers. The numbers are still extremely low for 1 and 2s. I wouldn't say that they have improved greatly from 2017
Why do you think that's the case?
because they still are going by the training that they're aware of and not being told to look at anything different.
I see.
That training has not changed.
And no concerns are being raised with you by the Home Office about
No.
the numbers now?
No.
Can we just look a little bit more at the training? You say you had training on Rule 35 several times. Was that the Home Office and NHS England training you're talking about?
Yes.
And you had it before 2017?
Yes.
And have you had it since?
No.
No. So what are the several times you're talking about?
I did have them listed, I think, in my statement. There's definitely some training in 2016. There was a training course put on in 2017, but I was unable to attend that one.
And
then-
was the training primarily for GPs?
Yes.
So your nursing staff weren't trained
No.
in Rule 35, as you've said before. Did they receive any training in when to refer for a Rule 35
No.
report? Do they now?
No.
How then are they to understand the importance of healthcare screening, either initially within the first 2 hours of arrival in a detention centre, or in a removal centre? I'm sorry, or afterwards, if they are not trained in when to refer for a
So
Rule
part of their orientation process, I do share with them and go through all of the DSOs and the DC rules, and they're all given a copy of those as well.
Rule 35.3 seems to be more capable of easy understanding because it relates to being a victim of torture.
That's right.
Whatever one thinks about the definition of that, it is at least, if someone says I'm a victim of torture, one can understand that prompts a referral for a Rule 35 assessment and report by a GP. Do you think your staff have a good understanding or an adequate understanding of the other two limbs of the rule?
No.
That's a significant gap in knowledge then, isn't
Yes,
it?
yeah.
And does that remain today?
Yes.
And you said as head of healthcare you've tried to source training, push for training, I think was what you said, several times. Have you approached, given your lack of success with the Home Office, have you approached any other body in relation to training?
I haven't, no, because of it being a Home Office policy and their DSO, it should be them promoting the training for their policy. And it's their document, so it's quite difficult to actually source specific for Rule 35s.
So you'd agree with Dr. Hard that the training is inadequate?
Yes.
It remains inadequate today.
And when I first started at the immigration centres, it was actually the nurses were undertaking Rule 35, of which we often do have more time to complete these. And now it's back to medical practitioners only completing, unless they're a short-term holding.
Yes. You mentioned nurses completing Rule 35 reports before. When was that?
This was I started in 2004, and the first couple of years at least I was doing them.
I see. And were you aware that even at that time, the rule certainly, the letter of the rule required it to be a GP?
We were told at that time that we could complete it, and it was, I think it was reviewed, and that's when they said it was medical practitioners only.
But the wording of the rule hadn't changed. You weren't aware of that?
No.
I see. Let's look then, as I promised we would, at the Rule 35.2 pathway briefly. It's at CJS 0073839. It's a one-page document. Were you the author of this?
I was, yes.
And was it in use in 2017?
No.
When did it come into
I
use?
think this was in response to following this review. Following, we had Dr. Linsell came from NHS England to do an inspection following the panorama, and it was
I
looked
see.
at then.
So following panorama?
Yes,
So do you think that was 2018 then, or?
it's likely to be
I see.
2018. Unfortunately, I didn't date it, but
We know also that this remains in use currently.
that's correct.
In Brookhouse, although I believe it's said to be under review by PPG, them having just taken over the
That's right.
contract. How would staff be aware of this document?
It's advertised in each of the clinic rooms, and the GPs have all got a copy.
I see. Was there any training or guidance provided by anyone on how to use the pathway, or did it speak for itself?
It was talked through at a staff meeting.
I see.
So staff meeting, they had it, and it's now part of we call the MPCCC, which is the multidisciplinary team meeting that's held weekly.
I see.
It's part of that.
And in your view, does this pathway comply with the requirements of Rule 35(2) from the wording of the rule?
No, this complies to how I've interpreted it previously.
I see. And is that because of the delay built in between day 1 and day 7 in a doctor considering?
Yes, but obviously I have put the asterisk there that if there is any serious concerns, then that is to be brought forward.
Yes. But it's the review by the mental health nurse is an additional step in between, isn't it?
Yes, it's to give that mental health background before the GP sees, so that gives the GP a little bit more to go through.
But if the nurse is concerned about suicidal intentions, there should be an immediate referral to a doctor, shouldn't there?
I think if they're that concerned, then there would be. That's why there is that asterisk there.
I see.
So,
So, in your view, does this pathway adequately safeguard the welfare of vulnerable detained persons with suicidal intentions, or are there still concerns over the interpretation of the rule?
there is still a lot of questions over interpretation of the rules.
I see. What the pathway does do is invites consideration of a Rule 35(2) report, albeit potentially some days later, by a GP when an ACDT has been opened.
That's correct.
And that's, as is said at the bottom there in relation to the weekly review, all ACDT cases.
Yes.
So not just those on a constant watch.
No. All ACDTs are reviewed. And if they're not for a Rule 35(2), then I recommend to the GPs is that they actually document not suitable at that time for Rule 35(2). So then it's actually acknowledged that it's been investigated.
And are GPs doing such documentation?
We've just had to sort of re-prompt it because they weren't. They had let it slip. And I have actually just re-put this through to the GPs again.
And because, and again, if someone is on a constant watch on an ACDT, that suggests suicidal intentions, doesn't it? It's the highest level of observations.
Yes.
So, in at least those cases, there should be a Rule 35(2) report, not just considered, but done. Is that right?
Yeah.
Are they being done?
No.
No. Why not?
I think it's the GPs are thinking, I can't answer for the GPs to be fair, but the GPs haven't done them.
And so the GPs aren't doing them. What action have you taken in relation to that as head of healthcare?
So I've gone through the Rule 35s again with them. We've had a recent gentleman with a mental health case that we have put through for Rule 35(1). That's been put through, and that was the first thing that I stipulated that needed to be completed. I think it depends on how long the patient's actually been on a constant watch for. If they're coming in, some people are only on a constant watch for a short time, and it can be prior to their flight leaving the following morning, in which case the GP may not see them.
Yeah.
That may be different, but if they are on it longer, then yes, they should have a Rule 35(2).
And if they're not, that's again a pretty serious failing in the system, isn't it? And your view of who's responsible for that is the GPs
And myself.
and the Home Office, presumably,
Yes.
because, as you said, they haven't raised the lack of Rule 35.2s with you. In your, let me just, in relation to ACDT, one of the medical justice witnesses, Emma Ginn, the Ginn or Gin, I'm unsure, her witness statement, she's the medical director of medical justice, her view is that because the ACDT system is not clinically led and is not therapeutic in its interventions, it's a risk management tool, and it clearly isn't leading to Rule 35.2 reports or indeed a substantial number of Rule 35.1 reports. The ACDT system is inadequate. Would you agree with that?
No, because I don't think the ACDT should be related to the Rule 35s. I think they should be separate, because I think there needs to be the boundaries between the clinical and the operational.
But doesn't your Rule 35.2 pathway, at least in relation to Rule 35.2, directly link the ACDT system with Rule 35?
Yes, but because the ACDT is not owned by healthcare, so therefore it shouldn't be coming from ACDTs to healthcare that way.
But if the concern as to why someone is being managed on an ACDT is a deterioration in their mental health due to being in detention or suicidal intentions, those things in themselves should be leading to Rule 35.1 and 2 reports, shouldn't it?
Yes.
So shouldn't, in those cases, the opening of the ACDT prompt the Rule 35 report?
It can do. It can do. I think it depends
But
on
it's
how.
not.
No, it's not.
In your Verita interview, at page 17, you say, I do find we get an awful lot of requests from solicitors and even occasionally from the Home Office to say you need to go and get a Rule 35 condition. I suspect you meant report. When actually it doesn't meet the criteria. We get a lot of pushbacks and they want repeats of Rule 35s. It used to be if you have one Rule 35 completed, then that was the answer. Now, if you don't like what was written, you can ask for changes to be put into it. If you move to a centre, you can get another one written at another centre. Sometimes you have had one response that torture should be the same no matter where you have been, and it's not re-happening, so it's not going to change. So you seem there to be saying that you were getting requests for more than one Rule 35 report and that was inappropriate. Is that right?
Yes.
Leaving aside Rule 35.3, which deals
That's
with...
what these were all regarding as threes.
I see. So, because that doesn't account for, does it, Rule 35.1 and 2?
No, that would be completely different.
So, because that concerns the impact of detention.
Exactly, and that can change at any time.
Exactly. So, that comment related only to Rule 35.3. I understand. Evidence from medical justice suggests that doctors in Brookhouse have refused to complete Rule 35 reports on detained persons because they already had one under Rule 35.3, when in fact what had happened was either an act of self-harm, perhaps indicating a deterioration in their health, or a suicide attempt indicating suicidal intentions. If a doctor was refusing a Rule 35.1 or Rule 35.2 report in those circumstances, where in the presence of a Rule 35.3 report, that would be wrong, wouldn't it?
Yes.
Were you aware of that happening at Brookhouse?
No.
Are you aware of it happening now?
No.
In relation to Her Majesty's Inspector of Prisons report on the unannounced inspection in October and November 2016, there was a conclusion reached that despite the long average cumulative length of detention, no regular healthcare checks were carried out to determine the impact of detention on the mental health of detainees. Combined with the general lack of oversight, this meant that there were no effective arrangements to monitor vulnerability over time. Were you aware of that conclusion in that report?
Yes,
Did you agree with it?
I did at the time, and we changed things.
Yes.
So we actually changed to do regular reviews, so people were reviewed. Anybody that had not been seen within healthcare within 6 weeks was actually then reviewed by healthcare to check that they were okay.
Thank you. Chair, I'm conscious of the time. I do still have some questions, but I'll try and be as quick as I can. I'm conscious it's 4:30. In relation to food and fluid refusal, you say that healthcare would see people who were on day 1 of fluid or day 2 of food refusal and do a full set of observations.
That's correct.
Including blood sugars, weight, and if required would be referred to see the GP. Is that right?
Correct.
So there would be some assessment of physical observations and physical condition. What would prompt a referral to a GP?
Abnormalities within their readings or big drops within their readings.
And was that solely focused upon the physical?
Generally, yes.
How would you assess the underlying reasons for food and fluid refusal? How would your staff?
It was actually, they were asked within that assessment why they were refusing. what
Was
the reasons
there?
were.
Was there a mental state examination?
Not a full mental state, because that wasn't always undertaken by the mental health team. If they were continuing it, then yes, a mental state would be completed.
Was consideration given to food and fluid refusal as a form of self-harm?
Not always,
Why not?
because a lot of them were refusing literally to prevent their flights as well.
So it was viewed as a form of protest primarily.
Yes. Some were self-harm, some did go to extreme. I've seen some extreme cases.
And was consideration given to refusal as a manifestation of mental illness?
Yes.
In every case, or
Not in every case, no.
but you would agree that food and fluid refusal can be a symptom of mental illness?
Yes.
So it's important to explore the reasons for food and fluid refusal in a therapeutic way
Yes.
and to make a clinical assessment,
Yeah.
both clearly of the physical implications but also of their mental health.
Yes.
That wasn't always done in 2017.
No, mental health nurses are now undertaking the assessments, so then they can explore more as well.
Do you agree that an assessment should also have been made of their mental capacity to make the decision?
Yes.
Was that always done in 2017?
Wasn't always done. It is now.
It is now.
Yes.
Use of force. You say at paragraph 148 of your statement that if there's a planned use of force, you would be called to the briefing beforehand, or would be alerted to who the detained person was, and would let staff know if there are any concerns.
That's correct.
If it's unplanned, you say you would get there as soon as possible.
Yes.
And the same presumably applies to your staff. Who from healthcare would generally attend planned or unplanned uses of force?
A general nurse or a stroke paramedic as our first responder, and then you'd usually have a second person, so then they could be a runner, and that could be a healthcare assistant, or sometimes it was even the mental health nurses.
But it wasn't routinely a mental health
No.
nurse who attended.
They'd often go for the review afterwards, because the height of the time of the use of force, that's not always the best time for them to be assessed.
No, I see. The decision to use force is not a medical or
No.
clinical one for healthcare. It's a custodial staff decision. the role that healthcare does have is in raising clinical concerns that may contraindicate restraint. Is that
Yes,
right?
that's
So in
correct.
other words, an important safeguarding role is healthcare before a planned use of force
Yes,
to raise a concern that actually this is someone we shouldn't be using force against.
yes,
From a clinical perspective,
yes,
that could relate to either physical conditions or mental health conditions,
Yes.
underlying vulnerability, risk of self-harm and suicide.
that's correct.
Presumably you agree that that's a very important
Definitely.
safeguarding role.
Definitely.
Were there occasions, so far as you were aware, in 2017 that that role wasn't being fulfilled by nursing staff?
No, I think we've always been very good on attending and completing the paperwork for them and in giving the correct information.
What about the raising of concerns that this person's too vulnerable and force shouldn't be being considered here?
I think if we had anybody that we did have concerns, we'd have raised it before a planned use of force was required. We do that as a preempt. Anybody we have that have got major concerns, we'll be talking to the officers and the Home Office to state that they're unsuitable for any use of force.
And was that happening in 2017?
I've known of one case where it was a physical condition that we said that they couldn't use force, and we had a multidisciplinary team meeting regarding it.
Were you aware of force being used on mentally vulnerable people due to self-harm incidents, particularly to relocate them to E-Wing?
Yes,
Did you think that was appropriate at the time?
I think it's depending on the individual case. I can't remember the specific cases, but it may be to safeguard them for their vulnerability for later on.
Should
So-
be a last resort, though,
Totally.
shouldn't it, a use of force?
Yes, yes,
To save life
yeah.
in the immediate moment.
Mhm.
A second important role is the monitoring of the detainee in providing clinical advice during the use of force itself. Is that right?
That's correct.
Would you expect the person fulfilling that role to be able to put themselves in a position to observe what was happening then in the
Yes.
use of force? Because one can't monitor and intervene if something's wrong if you can't see what's happening.
That's correct.
And you would expect your staff to know that
Yes,
and to act
Yes.
accordingly.
yes.
So if they couldn't see,
They make sure that they move or tell people to move out of the way so that they can see.
were you aware of decisions or advice being given by GPs in Brookhouse in 2017 in the context of fit to fly memos? In other words, a doctor certifying that someone was fit to fly
Yes.
to be removed.
Yes.
Were you aware that on occasion a doctor would say happy for reasonable force to be used?
I didn't see any of those documents.
And you weren't aware of it any other way?
No.
If you had been aware of it, would that have concerned you?
Yes, because it's not for us to decide on the
It's not
Force
for
being used.
healthcare to sanction a
No.
use of force.
no.
The documentation that healthcare are required to fill out following a use of force is called let me get it right, F213 form. There are lots of forms.
There are.
It's annexed to the DCF2, which is the use of force form,
That's
which is a
correct, yes.
custodial document.
Correct.
The F213 itself also has sections for custodial staff to fill in the first two sections. Is that right? You're
It is,
familiar
yes.
with the form?
Yeah,
The healthcare section is section 3. Is that right?
that's right.
And that contains healthcare's report as to the time and date of examination and the report itself. And it also contains body maps for recording of injuries.
That's
Is
correct.
that right?
Yes.
In filling out those forms, would mental health also be considered as well as physical injury?
Not generally, no.
No. Did that concern you, given that force was being used on vulnerable detainees who were self-harming?
It didn't at the time.
does it now.
Yes.
What process was in place at the time for auditing those forms and assessing the quality of healthcare's input on those forms?
All of the forms go together as a pack from the custodial team through to Home Office, and Home Office compliance will then come back with any comments as well.
And did they?
They've usually come back if we haven't signed, if a nurse hasn't signed, but that's generally it. It's not usually
Not on
about the quantity.
Not on the substantive
no.
quality of the report.
No.
Did internally, did healthcare carry out
No.
any audit of those reports?
No, because we don't keep hold of those reports. They go off to the custodial side.
I see, and is that still the case?
Yes.
At paragraph 150, you say you're not trained to do use of force, of
That's
course, because
correct.
you don't carry it out. Do you receive any training in the appropriate circumstances in which force may be used?
So nurses are allowed to go to use of force training, so then they can be a witness to the use of force and can actually be told how to stop the use of force should they feel they need to.
I see.
And we promote that with all of our team.
And was that the case in 2017, or is that just now?
I think it's more recently.
So there wasn't any such training at the time?
No.
Would
We
you
struggled to get the our own personal protection training in 2017.
Yes. Would you consider that a deficiency in the training in
Yes.
relation to use of force
Yeah.
for nursing staff?
Yes, because I think there was definitely staff were not keen to say stop either, if required.
And why was that?
Unaware and feeling that it wasn't there. They weren't in control.
They didn't want to challenge the
That's
custodial
right.
staff.
Yes.
So use of force was a custodial
Yes.
remit, not healthcare.
Yeah.
And so
We've had the security team and the use of force instructors come to staff meetings since then. We've promoted the fact that nurses are the ones that are the people that can say stop in the use of force.
yes,
To do emergency hands off.
in an emergency, but also to raise concerns over the effect of the force being used
Yes.
upon the detainee. And would that include on their mental health, if they
Yes.
seemed distressed, if they were vulnerable,
Yes.
if they had mental illness underlying? You'll be pleased to hear this is the last question. In relation to CQC inspections, can we just look at GDW 4011, please? So this is a report entitled The Right to Community Equivalent Healthcare in Immigration Removal Centres, a Public Law Analysis of Systemic Issues in the Inspection Regime. I think this report's been brought to your attention by the inquiry, is that right?
I haven't seen this actually before.
Okay. Were you aware of this report otherwise?
No.
It sets out very briefly a conclusion that the report, that a detained... Start again. It's a long day. It sets out that detained person healthcare complaints don't feature in CQC inspections in the same way that they do in CQC inspections in the community of GP practices. So the voice of the patient is effectively not heard. Would you agree with that?
Yes, it's very hard to get the patient to voice any opinions in detention. We've struggled for a long time to get any patient engagement.
And why do you think that is?
Whenever you go to any patient forums, they always just say, oh, healthcare's fine. And that doesn't give you any feedback. I think they've just got so many other things that they want to deal with. Food is often a priority for them, and their home office is their priority. Healthcare, that's not their priority.
I see. Is that a concern?
Oh, yes.
And what are you doing to address that concern?
So we've now got questions put out on all the kiosks. So whereabouts they order their food is a very short questionnaire that's available in all different languages, so they can actually access it, so that we can get some feedback and we can change those questions as appropriate. And we're also looking at getting a patient engagement lead nurse in as well, so we can actually get some further information back from the patients.
Thank you, Chair. Those are all my questions for this witness.
Thank
Do
you,
you
Ms.
have any
Simcock.
questions?
I do have a few, and I will try to keep them short. I need
Thank
them with
you.
us for a long afternoon, Ms. Calver. So my first question was, you told us a little bit about the IRC forums that I believe you established.
That's
and
correct.
chair those forums. Do Home Office staff attend those forums at all?
Yes, I do. I get a Home Office member from every IRC as well.
Okay, so it's your understanding that they would be familiar with the subjects that you're discussing. They would get copies of the minutes,
Yes.
for examples of those
Yes.
meetings. Okay, thank you very much. You also mentioned orientation for GPs working within Brookhouse. Is that something that you yourself put together as a kind of a training, a briefing?
Yes, it's very brief because obviously the GPs are a subcontractor, so we just try and give them as much. I give them the links to the DSOs, to the DC rules, and then anything specific that is for an immigration removal centre.
I'm correct in thinking that that's because you, in your experience, that's helpful for a GP who maybe doesn't have that experience of working in a detention environment?
That's correct, yes.
Okay, thank you. Then my final question. You mention in it's paragraph 9 of your statement, if you want to have a look, it's on page 2, your first statement. You talk about dips in morale and some of the sort of challenges that healthcare staff deal with. One of the things that you say is that factors which have caused morale to dip have been that we have, if we've had any specific challenging detainees, if we've had to run clinics without any officer support and then end up having to deal with verbal abuse from detainees. Can you tell me anything about how do you equip the staff that work within healthcare to deal with some of those challenges? Is it anything that's dealt with in terms of management relationships, mentoring?
So we've got the clinical supervision and management one-to-ones that we do with staff, and make sure that if they've got any incidents, we raise them for them as well and take it higher, but feed back to them as well, so they do get the flow of any incidents, issues that have been raised.
And is there any element of those conversations that's about finding ways to cope, strategies to cope with some of those challenges, like people speaking abusively to you because you're frustrated or those kind of things?
Not specifically, no, there isn't anything that we do specifically to get them cope. Obviously, they've got the employee assist programme that they can contact for any counselling advice. We've got that for all of our staff. But it's ensuring that we're doing as much as we can and we're getting involved and we do listen to them.
How often do staff have clinical supervision?
Monthly.
Monthly. Thank you. Those are all the questions that I have, Ms. Culver.
Thank
I'm very
you.
grateful. I know it's been a long afternoon, but your evidence has been important, and I'm
Thank
grateful
you.
for you taking this time to come.
Thank you very
Thank
much.
you.
Thank you, Chair. Tomorrow at 10 a.m. We will hear from Derek Murphy and then John Connolly.
Thank you very much. I will see you tomorrow at 10 a.m. Thank you. I hope everybody has a relatively smooth journey home.